Good afternoon, and thank you for joining us for today's webinar. Today we'll be talking about risk adjustment, quality measures, and care of older adults. I'm Paula Murray, an educator with HMSA's Provider Services Training Unit. Today we'll be talking about risk adjustment, what it is and why we need it. We'll also talk about hierarchical condition categories and risk adjustment factors. I'll be sharing with you how HMSA plans to work with providers to improve our RAF scores and improve chart reviews. Laura Adelberger will be joining us. She is our HMSA STARS Clinical Coordinator, and she'll present some of the exciting things happening this year with our Akamai Advantage plan, including our, do we have incentive programs this year? So our incentive programs and care of older adults in our dual care population, as well as medication management and COSEVA. I'll also cover some new reporting codes for quality and performance, provide you with some helpful tips to be successful this year, and we'll talk about payment transformation. And we've allotted some time at the end of our presentation for your additional questions. For our web participants, we'll take your questions via the chat function on your screen. Before we get started, I just wanted to go over some of the common acronyms we'll be using today. We have CMS, the Centers for Medicare and Medicaid Services, HCC, which are hierarchical condition categories, prescription HCCs, Medicare Advantage or MA, and RA for risk adjustment, and RAF for risk adjustment factor. So what is risk adjustment? In a nutshell, it's the process that CMS uses to reimburse Medicare Advantage plans based on the health status of members. This ensures that CMS pays plans appropriately for members' predicted health costs based on demographics such as age and gender, and health status such as claims data. Why do we need risk adjustment? Risk adjustment helps plans accurately reflect the health of our membership. The greater disease burden a patient has, the higher their risk score will be. A healthier patient will have a lower risk score, and it's these risk scores that enable CMS to accurately pay the health plan to care for its members. Okay, moving on to hierarchical condition categories. Introduced in 2004, hierarchical condition categories, or HCCs, are used by CMS for determining capitated payments for the Medicare Advantage program and other Medicare programs. When ICD-10 was implemented, diagnosis codes increased from 14,000 to over 69,000, and new codes are being added each year. About 8,600 of these codes are used in risk adjustment, and they're spread over 79 HCCs. The HCC codes allow payments to be risk adjusted based on patient complexity. The methodology uses a patient's documented 12-month diagnostic coding history to predict future financial utilization and risk. So in other words, it creates a risk adjustment factor or score for a patient that reflects his or her complexity. The score is then multiplied by a base rate and set to a per member per month capitated reimbursement for the next period of coverage, which would be the following year. An HCC code is a numeric code assigned to a category of diseases. Some of the more common and costly chronic diseases, such as diabetes, chronic kidney disease, congestive heart failure, and COPD, those are representative of what an HCC category would be. And this is an example of the HCC document that shows you for each RAF score, for each category, what the correlating RAF score would be. Just to give you an idea of how the hierarchy system works, here we're looking at two different charts. The first one is an excerpt from the CMS HCC list that we just looked at on the previous slide. And you can see the weighted score of a patient with diabetes, whether it's with complications or without complications. Then the second chart in blue is from the hierarchy document. This tells us which HCC category supersedes other categories. If your patient has been coded with diabetes with acute complications and has also been coded with diabetes with chronic complications, then CMS tells us that the patient would fall into the HCC category of 17. So 17 would supersede any patient's category with diabetes of chronic complications, which is 18. So you can see that in the far right-hand column. And another example, this patient is diagnosed with atherosclerosis of the extremities with ulceration or gangrene. So the patient may have been diagnosed with vascular disease, chronic ulcer or of the skin, or an amputation. But CMS tells us that if the patient has these conditions, the diagnosis of atherosclerosis of the extremities would supersede the other diagnoses. By looking at the RAF score associated with HCC 106, you can see why that's the diagnosis they would emphasize. A patient with this diagnosis would likely require more complex care and therefore have a higher RAF score. There are several factors that impact the patient's risk score, but primarily the HCC risk adjustment is based on the enrollee's health status and their demographic characteristics. The combination of the health status plus the demographic characteristics determine the patient's raw risk score. Since the physician cannot influence the age and sex of the patient, the real impact that the documentation of the patient's health status is by billing the proper ICD-10 codes. What should you be doing to ensure your ACCs are getting coded and accepted? At least once per calendar year, have an in-person encounter with the patient. Physicians care for and following proper guidelines, document care for the patient in their charts, and then the chart documentation is coded and submitted as a claim. In the risk adjustment and HCC payment model, physicians diagnose and report all of their patients' conditions, whether they're acute, chronic, or coexisting. The documentation is then coded and submitted via a claim to CMS, where the claim is either accepted or denied. The physician doesn't have to think about giving the patient a RAF score. They simply report the diagnosis codes on their claims, and CMS will apply the hierarchical condition categories and RAF scores to the member's data. CMS uses the risk score to adjust payments based on a patient's expected costs. Specific documentation of the patient's conditions result in more accurate reimbursement. And the patient's risk score is reset each year on January 1st. So looking at a coding example for risk adjustment, we have a 76-year-old female, so just based on her age and being female, she gets a risk score of 0.442, and being that she's Medicaid eligible, she gets an additional 0.151. So just without having any diagnosis, this patient's RAF score would be 0.593. Once a claim is submitted indicating that she has a diagnosis of diabetes without complications, that adds another 0.118. So if you just submitted that she had diabetes on your claim but didn't address any of her other conditions, her RAF score would be 0.711. But if you were to thoroughly code for all the conditions of the patient, it would increase her RAF score to 1.810, which is a really big difference over just having a basic score of 0.593 or 0.711, and that makes a big impact on reimbursement for that patient. Coding correctly for Medicare Advantage patients can mean an increase in payment of sometimes 2 to 3 times of the base amount, as you saw on the last slide. So many variables influence the rate paid by CMS to an MA plan, even for patients within the same geographic area. One of the most important is the hierarchical condition categories. Accurate coding helps identify the high-risk patients thereby allowing physicians to encourage patients to participate in disease and care management programs and prevention initiatives. So why is HCC risk adjustment important? First, it improves the quality of care through disease management programs. If you're letting us know your patient has diabetes, we can always refer patients to some of our diabetes programs. Second, accuracy in member health status profile. The more accurate our data is, leads to number 3, the appropriate risk premium from CMS. So once you submit accurate data to us, we can appropriately receive premiums from CMS, and that is passed on to our physicians. How does this affect you? The physician treats the patient who are on such as a plan such as our Akamai Advantage, funded through risk adjustment models. The provider documents and codes the diagnosis accurately to the highest level of specificity. The documentation and coding that establishes the complexity and workload of the patient panel. And then that becomes the basis for funding and reimbursement. So proper coding of your claims results in proper resources, not only proper resources to HMSA, but also proper resources for the provider's office. And why do we need to code our claims accurately? Because the claim is the primary vehicle with which providers communicate to us. Your claim information tells us how much work you've done with each patient. Our goal is to reimburse providers for the work they do. If your claims don't accurately reflect all of the conditions you're managing, evaluating, assessing, and treating, it translates into less payment. There's different characteristics that comprise the HCC model. It's prospective in nature. Diagnoses from the base year are used to predict payment for the following year. CMS only considers diagnosis from inpatient and outpatient hospital and physician data. Base payments for each member are based on HCCs that are influenced by Medicare costs for chronic diseases. Additional factors are applied when a hierarchy of more severe and less severe conditions coexist. And final adjustment is due to demographic factors such as age, sex, Medicare entitlement, disability, and Medicaid status. The CMS model is cumulative, and this means that it uses the historical diagnoses as a measure of health status to predict future expenses. So data from 2017 is used to predict costs for 2018. The model is also additive. This means you can add together as many risk adjustment factors as are appropriate for your patient. Patients can have multiple HCC categories assigned to them to indicate multiple chronic conditions. And some categories supersede other categories, and that comprises the hierarchy within the categories. Prescription HCCs cover many diagnoses which are not covered in the basic HCC model. As a general rule, almost all HCC diagnoses are also prescription HCC codes, but not all prescription HCCs fall into the basic HCC model. For example, hypertension is not a hierarchical condition category, but it is a prescription hierarchical condition category. Osteoporosis is another common one that's not a medical HCC, but does fall under the prescription HCC. Same thing with many behavioral health disorders such as phobias, manias, PTSD, ADHD, glaucoma, some migraine prescriptions. And the reason for this is the disease itself is not costly to manage, but the prescription drugs are very costly. Risk adjustment also relies on physicians to maintain accurate medical records to capture comprehensive health status and a complete risk profile of their patients. What can we do to improve? By staying up to date on best practices, HMSA will continue to have webinars and educational sessions regarding risk adjustment and hierarchical condition categories. By reporting a complete picture of RAF scores, physicians increase the accuracy of the patient's risk score and reduce the need to request medical records and the need to audit providers' claims. You may have noticed the suspect condition codes on your COSEVA display. This is another opportunity for physicians to identify possible diagnoses that may affect their patient's risk score. HCC streamlines the process of creating clean claims, and it allows for efficient reimbursement. HMSA will be taking a two-pronged approach to improving risk scores, retrospective and prospective. The retrospective chart reviews will continue for previously submitted claims where an opportunity exists to improve accuracy. We'll review the audit, and our findings will then be communicated back to the provider. We'll also be taking a proactive or prospective approach to risk adjustment, and I'll cover both of these in more detail in the next slides. HMSA will continue the retrospective chart reviews for previously submitted claims where there's opportunities to improve accuracy. This will ensure the accuracy of completed chart reviews and that accurate risk scores are submitted to CMS. Once the chart reviews have been completed, we'll perform an analysis and communicate our findings back to the provider. We'll perform an analysis, we'll be able to show gap opportunities and any financial variance between risk scores attained based on claims data versus risk scores calculated after chart reviews. HMSA will also continue to conduct training and education on risk adjustment basics to physicians, coders, and office staff. We'll also conduct performance management reviews with providers to improve accuracy and buy-in of submitting properly coded claims. And finally, we want to improve and maximize risk adjustment scores of MA plans to align revenue with the patient's role. On the prospective side, starting this year, we will be supplementing chart reviews with educational and administrative resources, training, reporting and analysis of our findings, incentive programs, and communication and outreach to help physician organizations, providers, and office staff improve coding and documentation. There are several factors that can have a negative impact on a patient's risk score. You may have patients with chronic conditions who don't see their PCP regularly to monitor or treat those conditions, or you may have some patients who you've seen for their chronic conditions but don't come and follow up with you on a regular basis. Maybe they only come in when they have some acute condition they want addressed. And of course, we also have those patients who just don't come to see their PCP annually unless they have something really acute happening that they need taken care of. These are all likely to have many missed opportunities for risk adjustment scoring. Your medical record documentation should paint a picture with words. If your documentation is incomplete, you could liken that to a puzzle that's missing pieces. Diagnosis specificity, so make sure you have your chief complaint, HPI, our review of systems, any comorbidities affecting the patient care. For a plan of care, be sure you're documenting conditions assessed and what's being done for that, whether it's prescriptions, ordering labs, or referrals. For accuracy, documentation must support the diagnosis being reported. Be sure to watch for conflicting data within your chart notes. And also, you want to document your cause and effect relationships. Additional strategies would be incorporate and document relevant findings into your progress note, and be sure to report your diagnosis codes at least once each calendar year. CMS acceptable signatures, you want to be sure that your chart note is signed properly, whether it's a handwritten signature or electronically signed, and CMS must be able to determine who the rendering provider was of that chart note. Medical documentation is time-consuming, so many providers like to use shortcuts or abbreviations such as, H/O for history of or SP for status post. If a condition is documented as being history of or status post, it indicates it's no longer an active condition and cannot be coded as an active diagnosis on your claim. For every active condition, there should be a treatment plan, such as a referral to a specialist, observation for exacerbation or worsening, and an assessment such as the condition is stable or worsening or not responding to treatment. Be sure you use linking terms when appropriate in your documentation to indicate a relationship between the disease and any manifestation. Linking words create a relationship between diseases and manifestations, such as anemia due to GI bleed. This assures your coder of a cause and effect between the disease and the manifestation. Your coder can't assume the relationship is there. If the relationship exists, it needs to be documented. Using the words due to is probably the most common linking phrase, but you can also use phrases such as secondary to or indications include, or you could also use manifested by, such as a GI bleed manifested by anemia. And another option would be to use word suffixes such as ic or iv to indicate conditions like diabetic ulcer or hypertensive heart disease. And that will also show the relationship between the disease and manifestations. For documenting specificity, here are some examples of how you could be more specific if you're documenting diabetes. Be sure to document whether it's type 1 or type 2, because type 2 is the default code. So if your patient has type 1, you want to be sure you're documenting that it is type 1. And also be sure to document any complications as well as insulin use. For bronchitis, you want to be sure you're putting down whether it's acute, chronic, or unspecified, and whether it's obstructive or asthmatic. For hepatitis, indicate whether it's hepatitis A, B, or C, and again, whether it's acute, chronic, or unspecified. For wounds and ulcers, you want to document if there's any trauma, underlying etiology, the location of it, and the stage. Also, when submitting your claims, don't forget to put in your Z codes, and that's going to give us a lot of information of the status of your patient that's sometimes overlooked. For amputations, you can put in a Z code to indicate whether they have an amputation, whether it's below the knee, or whether it's a foot or toe amputation. For their renal dialysis, if they're on dialysis, they have a fitting adjustment catheter or even the presence of a catheter. Anytime there's an organ transplant, there's a Z code for that as well. For BMI, indicate if your patient is morbidly obese with BMI over 40. And also, you always want to document your height and weight. Of course, that is also one of our performance measures in our quality program. If you have an HIV patient who's asymptomatic, there's also a Z code for HIV status. And same with artificial openings, there are Z codes for that as well that you want to be sure to include. Minimize use of nonspecific codes. These codes can dramatically and mostly negatively impact your reimbursement under the new payment models. As much as possible, you want to stay away from unspecified codes. It's critical that documentation and diagnosis coding accurately reflect the acuity of the patient's condition known and present at the time of the encounter. Use of an unspecified code may be appropriate in some cases and should be assigned when the documentation doesn't reflect a higher level of specificity. However, providers should identify scenarios where specificity appears to be under-documented or miscoded. Clinical documentation improvement and coding proficiency go hand in hand in supporting this critical initiative. Historically, fee-for-service reimbursement has placed emphasis on the CPT and HCPCS procedural service codes for professional claims instead of on diagnosis codes. With the rise of value-based reimbursement models and the focus on risk and outcomes, now is really the time to focus on accurate ICD-10 diagnosis coding and documentation. This allows providers to accurately reflect how their patients are categorized by payers and how their future reimbursements will be determined. Some tips and tricks to improve the use of ICD-10 codes. Learn the current ICD-10 coding guidelines and conventions to ensure that the correct codes are being applied. For example, many chronic conditions with complications have a combination code available, which should be used instead of listing the individual conditions, such as instead of listing hypertension and chronic kidney disease, use the code for hypertensive chronic kidney disease. Code from the medical record documentation. Don't rely on GEMS mapping or other crosswalk tools to assign your ICD-10 codes. The tools can be helpful resources, but they often lead to an unspecified code versus the specific code that's available for selection. And perform documentation reviews to validate the correct ICD-10 code is being assigned, and engage in provider documentation training on code selection. You can also monitor your coder productivity and quality to ensure the proper codes are being submitted for reimbursement. More documentation strategy is to ensure all encounters contain the patient's name and date of birth on each page of the chart note, the date of service, a proper signature from the provider as well as their credentials, compliant signatures including authenticated electronic signatures. Be sure it's not a stamped signature. And of course, document to the highest level of specificity. You know, as example, writing out benign hypertension versus just abbreviating HTN for hypertension. And all diagnosis must include an assessment and treatment plan. Just putting down a list of the diagnosis is not going to be sufficient documentation. So with including an assessment and treatment plan, let's talk about meat. We're always talking about meat, but it's really important that anytime there is a diagnosis, you need to have some aspect of meat documented in your chart note for each diagnosis. So whether you're monitoring it, monitoring the signs, symptoms, progression, or regression, make sure you're documenting something, whether you're evaluating the condition, is it ordering tests or evaluating test results, medication effectiveness or response to treatment. If you're assessing or addressing the condition, notate your discussion, review records and counseling. And if you're treating the condition, be sure to notate any medications you're prescribing, exercise or advice for therapies or other modalities that you're giving your patient. In HCC coding, you'll need to capture the hierarchical condition categories at least once every 12 months. And you're not actually capturing the condition codes, but just be sure you're putting in the diagnosis for each condition once every 12 months. You're probably already doing this with your Akamai review of chronic conditions, but you'll need to expand this to all of your patients. Sometimes physicians get familiar with the patients over time and neglect to document some of their chronic stable conditions. Ensure that the codes being billed on your claims are supported by proper documentation in your medical record. Be mindful of your meat. Each condition should have evidence of being managed, evaluated, assessed, or treated. If your patient has conditions where one diagnosis is linked to another, be sure you document the causal relationship or the manifestation codes. Review specialist documentation. You're probably already doing this in order to confirm or disconfirm your RCCs, but you'll want to expand that to all of your patients. And finally, for prescription HCCs, they complement the reimbursement for managing patients with illnesses that may not be as complex or costly as the HCC diagnoses, but they qualify for additional reimbursement to the health plans due to increased medication costs. So as a general rule, almost all HCC diagnoses are also prescription HCCs, but the reverse is not true. Okay, so that's the end of the first section of our presentation, and if you have any questions now, we can take that. If you don't have any questions, and I'm not seeing any right now, we're going to move on to the second part, which is coding for quality, and I'm going to turn it over to Laura Adelberger for that. I'm sorry, before we turn it over to Laura, I just want to answer the one question, where could we find the HCC listings? They are available on the CMS website, but we could also do a follow-up email and send you a copy of those. Okay, moving on to Laura.
Good afternoon, everyone. I really appreciate you taking some time out of your schedule to come and let us talk to you a little bit about coding. And I'm going to be talking on, it's related but similar to what you were just hearing about coding. So in addition to coding for purposes of RCC scores, we're also very interested in how coding affects Medicare Stars. So I want to just really quickly, in case there are those who aren't familiar with Medicare Stars, Medicare Stars is a way that CMS evaluates and rates different health plans. It's intended to allow beneficiaries to have an apples-to-apples comparison so that when they're making a choice, they're making an informed choice on which plan that they would like to select. Medicare Stars also encourages evidence-based practices in clinical areas through rewards to health plans and bonus payments when those quality measures are met. And its main goal for CMS is to improve overall health and well-being of our members. So what gets scored? Well, in addition to some metrics that are health plan specific, there are a number of clinical measures that Medicare Stars focuses on. Many of the metrics we track are familiar to you. They're going to be metrics that appear on your Pay for Quality and your payment transformation dashboards, things related to preventative screenings like breast cancer screenings and colorectal cancer screenings. There are chronic disease measures related to diabetes and hypertension, and several others that we manage that, like I said, they appear on your payment transformation boards. Okay, so why would you code for quality metrics related to STARS or related to HEDIS, which is overlapping? For one thing, reduces HEDIS medical record collections if you code for quality metrics. Not too many months ago, you may have had someone from HMSA or some of our fellow health plans making phone calls to your offices asking for medical records. For many of those records, if the coding is included on the claims you send to us, we don't need to come to your offices and collect those records. And so that can reduce the burden on your office right there. It also increases your quality scores and your payments that are related to payment transformation and pay for quality, because we're aware that you're closing those clinical gaps that we're requesting from you. And it can increase your cost of care payments for payment transformation and for MACRA through traditional fee-for-service Medicare. Paula alluded to some of that a little bit earlier in her presentation, because coding for specificity definitely influences the payments to the health plan, but some of those payments get passed along to our providers, our participating providers. And finally, there's a lot of work that you and your office are doing, and it gets you credit for that work. We recognize that it is completed. So there are two types of coding that affect quality metrics. The first is coding to close gaps in care. So in many cases, you might deliver a service. So you might perhaps give a patient a referral to get a mammogram. The claim comes to HMSA that gap in care is closed. So those are the easy ones. For some gaps, the more efficient way to document closing the gap is by adding a CPT-2 code to your claim. So, for example, you might have a dual special needs member come to your office for their annual wellness visit. This would be a perfect time for you to complete their Care of Older Adults assessment, which is a 4-part assessment that includes a medication review, a functional status assessment, a pain assessment, and advanced care planning. We do provide forms like the one that you're seeing on your screen that you're welcome to use to help you complete that assessment, or of course any form that you would like to use that includes those various metrics is fine with us. When you complete the assessment during this visit, you add the completed form to your medical record, and then you're ready to file your claim for that visit. You'll notice that on the form are some codes to help you know what CPT-2 codes will give you credit in HMSA's system for having completed those assessments. I have another metric that I'd like to talk about for a minute, where coding for quality really affects outcomes for us and allows us to track your work. And that's the medication reconciliation post-discharge. So for those of you who might not be familiar with this particular metric, the way this works is that a patient's discharged from the hospital, and within a 30-day window from that hospital discharge date, CMS is requesting that they have a medication reconciliation, a matchup of these are the medications that might have been prescribed when they were in the hospital, and these were changes or additions to the medications that were prescribed by you in the outpatient setting. So it's a matchup of the discharge medications with their pre-admission medications. So you would want to document that you did this in the chart. Discharge medications were reviewed and reconciled with pre-admit medications. And you would want to document that on a claim using the CPT-2 code, 1111F. Now, we are trying to give our providers some support with this measure also. You'll notice on the right-hand side of your screen a form. If you want to carry out this reconciliation yourself and are interested in having some of these forms, they're available on the provider portal. But some of you may have also noticed that these are being faxed to your office with all of the medications filled in from the discharge summary and from our claims information, with some review by one of our internal pharmacists. So we hope that you're finding those to be useful and interesting, some good information on those. And when those forms arrive, please feel free to look through that form, and then on the next time your patient comes in for a checkup or for a visit with you, then you can still code on your claim that you did the medication reconciliation using that CPT-2 code. All right, I want to switch gears just a teeny bit because I'm still really talking about claims and coding and how coding helps us close gaps. In this case, I want to talk about how coding affects one of our disease state metrics for rheumatoid arthritis. The basic metric that we're tracking here is that a patient who has rheumatoid arthritis is being treated with a disease-modifying anti-rheumatic drug, or a DMARD. We've done a lot of outreach. Some of you may have gotten faxes from us asking about the treatment plan for your patients who have rheumatoid arthritis. And what we're seeing is that while we certainly have plenty of patients who are being treated perhaps with a non-formulary drug, they may have refused treatment or be treating with an anti-inflammatory. Those who are not on a DMARD, one of the other things that we see commonly is that there may be an error in the diagnosis. So we ask that you are very careful when you're diagnosing rheumatoid arthritis. There are some similar diagnosis codes that may be more accurate for reflecting what's going on with your patient and their specific disease state. We also see quite a few patients where we're hearing back that those patients are in remission. And so we're asking if you're comfortable with that code, that you consider reporting the Z code shown at the bottom of your screen to indicate a patient who is in remission with their rheumatoid arthritis and therefore does not need to be treated at this time. So I said that there were two types of coding that affect Medicare Stars and quality metric outcomes. The second type, in addition to coding that specifically closes a gap, is coding for burden of illness. And this is really what Paula was talking about as far as having accurate and complete RCC codes. But in addition to affecting what we understand about your panel, it also directly can affect Stars metrics. One area where it affects Stars metrics is through hospital readmissions. So hospital readmissions, a patient's admitted to the hospital, and then within 30 days, something has happened and they need to be readmitted again. This obviously has a large impact on our patient population. No one really enjoys being in the hospital. And it also has an effect on cost. But the thing that's important about this, as far as coding is related, is that when a population that has a higher burden of illness is expected to have a higher rate of admission and readmission. So by coding the full burden of illness in your patient population, you're actually affecting what our expected readmission rate will be, which can help us do a little bit better on our overall comparison to other health plans when they can see that, okay, we do in fact have sicker people, and so we need more time in the hospital to make sure that they are healthy. The second measure that I'd like to talk about is a fairly new one. This one may also be unfamiliar to you. So this is the measure of potentially preventable complications. So this is hospitalizations that are related to several chronic conditions, which you can see listed on your screen, as well as some acute conditions, which are listed on your screen. And again, we're looking at a metric that is scored on observed hospitalizations versus expected hospitalizations, which means that a population that has a high proportion of diabetic members with complications would be expected to need more time and more care in the hospital than a population of diabetics that are very well controlled with their A1C scores. So we ask that you do your best, again, to code to your highest specificity because it's directly related to our overall score on some of these quality metrics. So I'd like to leave you with a couple of thoughts related to Stars and quality metrics and how your coding affects the overall quality of the health plan. The first is we do ask that you use CPT2 codes where you can to report quality care. That allows you to close gaps in care and to report the work that you're completing. We also ask that you code burden of illness to the highest specificity because it does affect measures that are risk adjusted. And finally, if you need guides to helpful codes for quality measures, on the Medicare STARS page, which is located in the Medicare program section of the provider portal, there are quick reference guides on coding for Medicare STARS ratings, and we would be delighted for you to check those out and use some of the tips that are available there. We'd also like to point out that the Payment Transformation Coding Guide contains some of these Z codes and CPT2 codes and things that you can use to close your gaps in care and help us to know about all the work that you're doing. So thank you so much for your time, and if there are questions on my section, I would be happy to take them.
Okay, so we can come back to any questions if you have them at the end, but for now we're going to take a closer look at the new performance measures and how you'll be reporting them on claims. We want to emphasize that in our quality program, all codes on claims submitted to HMSA, whether that claim is approved or denied, are recognized for, they count for numerator credit. However, you still want to be mindful of which codes you bill because some CPT codes may trigger a member co-payment. For instance, if you're seeing a patient for an annual wellness visit, there should not be a copay. However, if that claim is coded incorrectly, it could result in the member owing a copay. Since many of the performance measures are also preventive services recognized under the Affordable Care Act for compliant plans, we've been asked by PCPs how to know whether a commercial member plan is ACA compliant, and we have some instructions on checking that in HIN. So once you go into HIN, you can enter the member's information, pull up their plan. Look for the section titled Special Instructions. Under the Special Instructions, there's going to be text that says, this is a non-grandfathered Patient Protection and Affordable Care Act, or PPACA, compliant plan. So when it says it's a non-grandfathered plan, that means that plan is subject to all ACA benefits. If you're also looking in HIN under for ACA benefits under routine preventive care for HMO plans and under preventive services, it's listed for PPO and ACA individual HMO metallic plans. So there is a couple different places that you may need to check depending on which type of plan that patient has. Moving on to our Sharecare Real Age Assessment. Wellbeing 5 was our old performance measure that we were doing, but we've moved on to the Sharecare Real Age, and this is applying to commercial members 18 and older who complete the Sharecare Real Age Assessment at least once during the measurement year. And the Sharecare Real Age Assessment gauges how fast you're aging based on your lifestyle and medical history, and it compares that with your chronological age. So if you haven't already had a chance, take a moment and go to the link that you see on your screen. You may be surprised at whether you are a little bit younger or a little bit older than your chronological age. For pediatrics, pediatricians have date-driven measures, and some of these have to be completed by a child's specific birthday, such as immunizations by the second birthday, and others count if they're completed within the calendar year. So birthday rule in payment transformations measures with due dates determined by a child's birthday. So your well child visits before age 15 months, and childhood immunizations by the second birthday. Also, there's developmental screenings that need to be completed before the child's first, second, or third birthday. For the calendar year rule, measures there are measures that count only if they're completed within that calendar year. So well-child visits in their 3rd, 4th, 5th, and 6th years of life, any visit during the measurement year will count, and it can be before or after the birthday, but as long as it's been at least 9 months since the previous well-child visit. For adolescent well care, any visit during the measurement year will count, and again, it has to be at least 9 months since their previous well care visit. So here's some pointers on patients aging into measures. Essentially, if a child will turn the qualifying age for that measure by the end of the year, then you're going to see that red dot in COSEVA saying that you need to address the measure. So for instance, if your child is 12 years old when you see them in February, but their birthday is in December, you're going to see a red dot indicating they're due for a meningococcal and Tdap immunization. So you can go ahead and plan ahead of time how to close gaps for patients who are aging into measures. So for pediatrics, we have a list here. I'm not going to go through each one individually because you're probably more than familiar with these measures already, but just for you to have them all in one place, we put together a little kind of cheat sheet of the age it's due and which measure it's affecting. And same thing for adolescents. For adults, we have the listing of the age range and which measures they apply to. Those haven't really changed too much. I don't see anything jumping out at me. I mean, flu vaccine is kind of new, but that's going to apply to our offices who are in performance measures of payment transformation, as well as for tobacco cessation, depression and anxiety screening. Those are all payment transformation measures. If your group is still doing pay for quality measures, you'll see those as display only in COSEVA. Advanced care planning, that's expanded to patients age 65 and older. Same as review of chronic conditions, those have always been 65 and over. And for all patients, of course, you want to check on well-being of all patients in your panel at least once a year. So some success strategies for your office workflows. For pre-visit planning, and that's going to be before your patient actually comes in for their appointment, you'll want to take a look at your schedule of future visits, review that, check COSEVA for any outstanding care gaps. So depending on your current office workflow, you could flag gaps on your face sheet or encounter forms, your super bill, or if your EMR allows you to put alerts in, you could do that. For your Akamai Advantage patients with RCC care gaps, you could go ahead and print out the patient's RCC list from COSEVA by clicking Print Screen, and that way we can be sure the physician doesn't miss any of those chronic conditions that we are already aware of. And, of course, check for any reports from specialists that may need to be addressed. Say they went and had their colorectal screening done from an outside source or clinic. You want to be sure you have that report on hand so you can close that gap if you're still seeing a red dot for that. Then when the day of the appointment actually comes along, as part of your check-in process, you could have the patient complete the clinical depression and anxiety screener in the waiting room. Be sure to get your patient's vitals, height, weight, BMI, blood pressure. If the blood pressure reading is initially a little higher than we'd like to see it, you could repeat it as many times as you feel appropriate within that visit, because a lot of times once the patient is feeling a little more comfortable, their blood pressure reading will drop a little bit and fall into the compliant range. For tobacco screening, all patients age 18 and over, be sure to ask about smoking status and document it in their medical record, and then go ahead and put the appropriate codes for that on your claim. We do have all the codes necessary in the Provider Resource Center under Payment Transformation if you need to see a list of those codes that will take care of those red dots. You want to put those codes on your claim. Continuing with patient check-in, check for their care gaps. If the patient says they completed any of the screenings but you don't have results, ask the patient to sign the release of information form so you can go ahead and request the records from the specialist. For flu vaccines, age 18 and over, a lot of times your patients may be getting their flu vaccine from outside clinics or other sources. If they have gotten that, you could get the information from whether that's Minute Clinic or wherever they went. You need to get that information from the patient and then contact them. They can tell you the date of the flu vaccine and what serum they were given. You can enter that in your supplemental data. For advanced care planning, that's going to be an annual update. Your physician can do that in the office, but we also allow this to be updated over the phone. So there's some telephone codes you can go ahead and do supplemental data for that. If you need the post form, those can also be found at kokuamau.org. So once your patient is in the room with the physician, they probably will have their RCC list with them if it's applicable to that patient. You want to make sure you're documenting meat for each condition and coding at the highest level of specificity for each attested condition. And if you're disconfirming a condition, you want to go ahead and enter the appropriate text in your disconfirm inclusiva. For advanced care planning, go ahead and document your discussion and code that appropriately on your claim. For adolescent well-care visits, your medical record should show evidence of all of the following: that health and developmental history, physical exam, health education, and anticipatory guidance. And then once your patient's visit is complete, as they're checking out, go ahead and schedule any follow-up visits as needed. Schedule tests or procedures the doctor's ordered. And a lot of times if your patient needs to see a specialist, if you can assist them with making the appointment, they're really much more likely to follow through, more so than if you're just telling them to go ahead and call the office on their own to schedule the visit. And last but not least, I just want to point out, make sure you collect your co-pays. Some offices feel they don't have time to check eligibility and how much the patient is going to owe for their copay while the patient is there. But if you use HIN, you can do a little bit of pre-visit planning by knowing ahead if they have a flat rate copay or an 80-20 or 90-10 co-insurance, or if they still owe a deductible. You always want to be sure you have your patient's most current insurance information. And a lot of times, collecting your co-payment at time of service will save your office a lot of money in collection efforts later on. In April 2016, we started our payment transformation pilot with about 120 physicians, and it's been a time of learning. We've received a lot of feedback from physicians and their staff, and we're continually refining the payment transformation program. This year, we're adjusting the implementation schedule, which allowed PCPs to move a little slower into payment transformation. So we have two key components to the payment transformation program. First was the adoption of the global monthly payment, and the second part is the transition to the new payment transformation performance or quality metrics. So we have some PCPs who began full payment transformation on January 1st, and that was global payment and the new measures. Then in April, we had some PCPs who joined global payment, but they remained on pay for quality measures through the end of this year. Starting in January next year, they'll be moving on to the new measures or performance measures. And on July 1st, our last group of PCPs began global monthly payment. They're also still on pay for quality measures. So some of what you hear today applies to you if you're payment transformation measures. Some of it still applies to pay for quality. But by next year, January 1st, we'll be having all of our physicians fully in payment transformation, all on global payments and all doing performance measures and in the new COSEVA display. So this is just kind of a reference of the different groups and the different transition rates that we have going on. Some important announcements. Let's see. In 2017, we made a change to the global payment. We moved it over to the 15th of the month, and this allowed us to get patient attribution from 1 month earlier, as opposed to when we first started out, we were doing global payments the first week of the month, but we had to use attribution from 2 months prior. So this was an improvement to bring the two closer together. New engagement measures for the PCP to build their profile on Sharecare. We were asking you to complete that so we can update our Find a Provider application. Be sure you've completed your profile. You'll receive an email back from Sharecare. You'll need to reply to that email by clicking on the link, and that will be completing the measure. You need to click on the link, and that has to be done by December 31st. For the performance measure, Wellbeing 5 has transitioned out, and we're replacing that with the Sharecare Real Age Assessment. We do have tools available for Sharecare Real Age, as we did with the Wellbeing 5 little notepads where you can write down your patient's biometric information that will help them to complete their Sharecare Real Age Assessment. So it has information such as their blood pressure or any current labs they have, such as their cholesterol level. And of course, your report to provider gives you more information about the processing of each claim, and it'll help you with reconciliation as well. Okay, so that's the end of the presentation. We'll be here for a while. If you have any questions, go ahead and type those in the chat box. So I can see we have one question up here regarding discharge medication reconciliation. Is it for hospital admin only or ER visit also? And I'm going to turn that over to Lara to answer.
Yes, so the medication reconciliation is for following a hospital admission, not an ER visit. So if the ER visit results in an admission, then it will count for the medication reconciliation measure. But if they're just, there for a couple of hours or whatever that visit might entail, but are not admitted, then we're not looking for a medication reconciliation to be completed.
Okay, while we're waiting for any other questions that you might have to be typed in, I just wanted to mention that regarding risk adjustment and hierarchical condition categories and all of that fun stuff we talked about, we are working on putting up a specific page in the Provider Resource Center regarding risk adjustment. Right now we have a page just for payment transformation where you can find all of the tools and links that you need. We are working on one for risk adjustment, so once that's up and running, we will definitely get that link out to everyone. Okay, so we have a question. Is there an HCC list with the corresponding RAF score available? There is a list, and we'll go ahead and send that out in our follow-up email. How soon can we get that out? We can probably get that out to you either by the end of today or by tomorrow. And once we get our risk adjustment page up in the Provider Resource Center, we'll also have it there as well. Okay, how do we identify patients in our panel that are dual special need?
This is actually a great question, and I'm really happy that we finally have a good answer to this because this has been an issue for our providers, I know. The easiest way to identify your dual special need patients who need a Care for Older Adults assessment is to use your COSEVA page. If you scroll down I know that page is getting longer and longer with all the different quality metrics that show up on it. But if you scroll down towards the bottom, there is a section on your dashboard that is marked STARS Metrics. I think it says STARS Metrics for display only. And in that section, you will be able to see the members that are dual special need and need a care of older adults assessment. They'll have little red dots on their, when you're doing your pre-visit planning, if you pull up a member and they need this assessment, then they will show up with the little red dots on your regular page as well. But if you want to see sort of how many patients you have that are eligible, that's all in that section on your dashboard. And some of the other STARS measures that are also not included in payment transformation are in that section too. So if you have other quality metrics that you're interested in tracking and seeing how you're doing, our osteoporosis measure, for example, and I believe rheumatoid arthritis is on there now too, you can see those and see which patients fall into those measures.
Okay, anything else you want to mention while we're reading? Medication tracking in COSEVA?
Yeah, medication tracking in COSEVA, actually one of my very favorite screens to go check out for some of our members. If you want to know how your patients are doing on medication adherence, if they're taking the medications that you prescribed for them, or at least filling them, because of course, you know, we can't really tell for sure if they're actually taking them, but we can tell if they're picking them up. There is a screen on COSEVA that lets you see that fill history and what drugs they're filling, and will show you medications that are being prescribed by other healthcare providers that treat your patients. If you go to the right-hand side, once you've pulled up a patient that you're interested in, on the right-hand side there's a little radio button that's marked RX. And if you click that radio button and then click on any one of the drugs that appears in the list, it will take you to a screen that is specifically related to when the fill dates were, and you can see, you know, there's a calendar view with a graph where you can see that they've filled it and it lasted, you know, and then immediately they filled the next prescription, or whether there was a gap in fills. So very, very helpful, especially if you want to see, you know, really what's going on. Sometimes that can be a great clue to, if you've got a patient whose hypertension is not staying under control, and they're telling you, yes, I'm taking my medication, but then you can go to that page in COSEVA and see, oh, you know, there's some gaps. So yes, they're taking it, but they may not be taking it quite the way you prescribed it. So that can be a great way to just sort of get some hints about things you might want to ask when you're talking to your patient the next time.
Okay, this is regarding if a referral is written to address a care gap, then the care gap will be fulfilled. Is that correct? Actually, if you're writing a referral for your patient to a specialist, the care gap is not automatically fulfilled. It's not going to be fulfilled until that specialist submits a claim to HMSA with an appropriate code to close the care gap. And not all of the specialists are aware of what's happening in payment transformation or performance measures. So that's why we ask you, if you referred your patient to a specialist, you want to get the report back, review the report, and you may have to put in supplemental data to close that gap. Or if perhaps that report came back negative, you want to do an R for R or a request for reconsideration to remove your patient from that denominator. I hope that kind of answered your question.
Yeah, I think I might have been something that I said that brought about that question, because sometimes, you know, the referral is really your way of addressing the care gap, is giving a referral to your patient to, say, perhaps get their colonoscopy. But you're right, the patient has to fulfill that exam and complete that test before the care gap is actually closed.
Okay, I don't see any other questions at this time. Oh wait, sorry, one more. We have a significant, oh, sorry, can we scroll back up? We have a significant shortage of specialists on the Big Island. Currently, it is taking over 3 months to see a GI and 6 months to see a cardiologist. What should we do?
That is a difficult question, and we acknowledge that that's a problem. One possibility, although I'm not sure that this works for cardiology, we do have some specialists that are available through online care, which is a benefit that many of your HMSA members will have. So it's a possibility. It's perhaps not the perfect solution, but if there is an urgency to see someone, then they can do an online assessment for many conditions.
What care gaps can be completed by telephone? Right now, I believe there are, I think, 4 care gaps. You can do advanced care planning over the phone. We're working on children with special health care needs screener, but we're asking you not to do those over the phone just yet. We do need to get more specifics out to the community on how we want those reported. Trying to remember off the top of my head, sorry.
The Care for Older Adults assessments, they can be done over the phone. At this time, there are codes to report to HMSA that you did a phone assessment on a patient. At this time, however, of course, since I'm talking about Care for Older Adults, right this minute, those are not in the Medicare fee schedule. So HMSA is not paying for Medicare members who have a telephone assessment. I am hoping that that will show up in the fee schedule for 2018, so I'm not positive what the answer is to that yet. But you probably could also do the tobacco screening over the phone. Correct, Paula?
Yes, tobacco screening can be done over the phone. If can we scroll back up to the question? So I can't think of it right off the top of my head. I'd have to close my screen to look it up, but we do have a document in the Provider Resource Center on the Payment Transformation page that lists which care gaps can be closed over the phone, and we also have the instructions on which, how you can do the supplemental data to indicate that those were closed. And I can send that to you individually, or I can send it to the entire group along with the HCC sheet this afternoon. We'll just go ahead and send that out to everyone. So you're having trouble closing care gaps, and are you going to start being penalized because we cannot close care gaps? It's really not that you're being penalized for not closing care gaps. You probably won't be able to earn 100% of your performance or pay for quality dollars, depending on which program you're in right now. But you're not being penalized per se, because there is an expectation that we never did expect 100% of patients to be 100% compliant. So that was kind of built into the program. There's always an expectation that we know there are patients out there who will refuse to do mammography screening or cancer screening or to give their children vaccines. So that little bit of cushion is already in the program.
Yeah, I'm seeing a question that says, can you do an annual wellness visit and a Care for Older Adults assessment at the same visit? Yes, you can.
Okay, several of my patients have BMI as a care gap. However, we bring them in and then their office visit is not covered because they do not have any complaints. How would you code for this kind of visit? If you're bringing them in just to do a BMI, I don't have a good answer to how you would get around that. If the patient were to come in for any kind of E&M visit, of course you would be billing for an E&M, and you could include the BMI codes on their claim. So what happens is anytime they see any provider, they get put into that BMI denominator. Of course, if they go to get an eye exam, your ophthalmologist or optometrist is not going to be taking their height and weight, so we can't get it from them. And maybe that's something we can look at in the future as something that could perhaps be done as a supplement, because we wouldn't want you to file a claim just to get your BMI in and cause your member a copayment when they really didn't have any reason to be there in the first place. And, part of the whole premise of payment transformation is, we want to reduce those unnecessary office visits so that you can focus on the patients who really do need more care.
I can also tell you that if it happens that those patients who need a BMI are Akamai Advantage members, you can always do the BMI when they've come in for their annual wellness visit, which will be a covered service when they don't have any complaints, because that really is just a touch base with your patients.
Yeah, so we do understand. We have the older group, the Akamai Advantage, they do have the benefit of an annual visit, and we have our pediatricians who more or less have, not every year they have a visit, but they do have well-child visits. But then we have that in-between group who, a lot of our commercial plans don't have like an annual physical exam built into their benefit, so we understand that's where the challenge is with the BMI, as well as, getting some of the other measures such as blood pressure readings, but that's really only required once they've been diagnosed with hypertension or diabetes. So these are things that we do take into consideration. We take it back to our work groups internally to see if we can find solutions for these.
Well, we will definitely talk about this one, but I do want to point out a little more specifically that BMI will only come up as a gap to be closed if that patient has had a visit. Now, it may have been a visit with a specialist, but they shouldn't be in the BMI measure unless they have been to see a doctor of some sort. Now,
okay, so let's see.
Okay, yeah.
Yeah, so once a patient is attributed to you and they're in your patient panel, any gap in care will show up in your COSEVA, including a BMI. But we can get, we are definitely going to look at how we can work on closing that BMI gap without causing a copay for the patient, especially if they have no other conditions that they need seen for at the office. Okay, so it looks like that's probably all of the questions coming up right now. I want to remind you to please take a moment to fill out your evaluation form and either fax or email that back to us. The fax number and the email address are on the bottom of the form. Thank you so much for taking time out of your day to join us. We really do appreciate you taking time to spend with us today, and we appreciate all the work you're doing with our members and your patients. And hopefully we'll see you at some future webinars. Have a great afternoon.